Good morning. Today I'm going to talk about lipid reduction and those options that we can utilize to beyond the statin therapy and look at other options in our toolbox. I have no conflicts of interest. And again, the objectives today, I'm going to talk about advanced lipid management. I'm going to review different pharmacotherapy options with other statins. And I'd like to highlight research outcome data from randomized controlled trials demonstrating this and integrating the most recent guideline recommendations from the American Heart Association, American Stroke Association in 2021 for secondary stroke prevention. The type of patient that we're talking about here, we're talking about atherosclerotic cardiovascular patient who are high risk for another event. And advanced lipid management could be appropriate if their lipid profile is not at goal. Patients who have been refractory to therapy, in other words, unable to further lower their LDL with current therapy. Patients not at goal on a max tolerated statin, whether that's high intensity, moderate, or low intensity. Patients with a prior side effect who cannot tolerate another statin, for example, myalgia or elevated liver enzymes, and complex dyslipidemia, for example, patients with also hypertriglyceridemia in addition to elevated LDL. And again, this is kind of the description here of the clinical atherosclerotic cardiovascular disease patient, someone with ischemic stroke or TIA or coronary artery disease, all of which with atherosclerotic origin or etiology. Those with very high risk of future atherosclerotic cardiovascular disease would be someone with 2 or more major atherosclerotic cardiovascular disease, or at least one major atherosclerotic cardiovascular disease event and multiple high-risk conditions. I think you could think about your patient population and see that many of our patients do fit in this category with ischemic stroke. The statin therapy, the options kind of outlining with statins, high intensity therapy with LDL reduction of greater than 50%. And this could be atorvastatin 40 or 80 milligrams, rosuvastatin 20 or 40 milligrams. Moving down to moderate intensity with an LDL reduction of 30 to 50%, and those are some different options there, and low intensity, less than 30%. In general, statins are very well tolerated. I would say less than 5% of patients may have some sort of symptom, and again, the most common that I see in in our clinic would be myalgia or maybe elevated hepatic function panel. And looking at different lipid therapies and how that affects lipoprotein metabolism, I've talked a little bit statins, but I really want to focus on ezetimibe or PCSK9 inhibitors, such as Repatha or Praluent, and a newer medication option, bempedoic acid. And I will also discuss long-chain omega-3 fatty acids with Visipa in lowering triglyceride level. And just a kind of a reminder from a molecular level, what we're talking about with lipoproteins, HDL, high-density lipoprotein, that's your good cholesterol, and LDL, low-density lipoprotein, bad cholesterol, in addition to very low-density lipoprotein and chylomicrons, contribute to atherogenic lipoproteins and contribute to atherosclerotic disease. So LDL with the greatest percentage of cholesterol content, and our data outcome trials and cholesterol studies across the years have really focused on LDL, and that's why our recommendation guidelines have recommended a specific LDL threshold for prevention. And in terms of ezetimibe or Zetia, this is a different type of mechanism of action compared to a statin medicine. It reduces the cholesterol absorption in the gut. It's combined in addition to statin for LDL lowering, can provide additional lowering 13 to 20%. In general, the side effect profile is generally well tolerated, and important to note that in a geriatric population, tolerated just as well as in a younger population. It's an oral medication taken once daily. It's a good option economically, and very good outcome data with the Improve It study that was published in 2015 with the New England Journal of Medicine. And in this study, there were over 18,000 patients that were hospitalized with acute coronary syndrome. So this was not a stroke study, but it did have ischemic stroke outcome measures. The baseline LDL for patients in that study were 50 to 100 milligrams on a max tolerated statin. The therapy options were simvastatin, 40 milligrams, which is moderate intensity, plus the treatment drug ezetimibe, versus simvastatin, the moderate intensity intensity drug alone. This was a 7-year trial, and the average LDL reduction was 50 in the treatment arm versus close to 70 for simvastatin alone. And in terms of primary endpoints, the event rate was increased with simvastatin alone and decreased in the treatment arm 32.7% with simvastatin and ezetimibe. It correlates to an absolute risk reduction of 2%, and in other words, the number needed to treat to show some benefit would be 50, and that was clinically significant. And you can see with the Kaplan-Meier curve there that the benefit emerged after 1 year. But what's really interesting is looking at the tertiary outcome data points with ischemic stroke. And this did show some benefit with a 40% reduction in total stroke with a number needed to treat for stroke prevention of 12. And for ischemic stroke, this did show benefit within 6 months. So really great stroke outcomes with ezetimibe. Now we'll move on to the injectable type medications. There are two formularies, two drug options, Repatha and Praluent. Repatha is available in every 2-week dosing, SureClick pen, or every 4-week with a Pushtronics injectable that's attached to an area that you can apply subcutaneously, and it infuses over 8 to 9 minutes. These are stored in the refrigerator. They're safe at room temperature. They may be, require insurance approval and might be more expensive for our patient. But with proper documentation of atherosclerotic cardiovascular disease risk and with those patients on max tolerated statin, whether that's high intensity, moderate, or low intensity, or no statin, if they're on max tolerated, could be combined in addition with the PCSK9 inhibitor. There's long-term safety data that demonstrates that it's well tolerated in patients with a very favorable side effect profile. The mechanism of action is different than the other cholesterol-lowering medications, and I like to point this out to our patients, those who may not have tolerated statin therapy before, looking at this in a different frame of mind. This is proprotein PCSK9 inhibitor, which could attach to the LDL cholesterol lipoprotein and the LDL receptor, which is engulfed in the cell membrane and degraded. With an inhibitor, you're inhibiting that proprotein, and the LDL receptor gets to be reuptake back to the cell membrane where it can capture more LDL cholesterol lipoproteins. So there are two major trials for the PCSK9 inhibitors. The first one published was the Fourier trial. This is looking at Repatha, and more than 27,000 patients were with atherosclerotic cardiovascular disease, including stroke. Were in this study. It's over 2-year follow-up. Patients with LDL of 70 or higher on statin therapy. And you can see with the treatment arm that the LDL was really brought down. And this correlated with a relative risk reduction of 21% for ischemic stroke, 27% risk reduction for myocardial infarction, and no mortality difference. And you can really see the difference and how that clinically significant risk reduction for prevention. The Odyssey trial is looking at Praluent, and this is similar to the ezetimibe. It was a study, a cardiac study for patients with acute coronary syndrome up 1 to 12 months post-event, and the follow-up was 2.8 years with the LDL 70 or higher on statin, with the treatment arm showing significant LDL reduction. The outcome similar to the Fourier trial, where there was a 25% risk reduction of ischemic stroke, 15% reduction in MI, myocardial infarction, and 14% mortality reduction. And in terms of, if you're wanting to have a tool for a flow chart and decision tree, which component, which medication to choose, I like to use this. This is from the cholesterol guidelines in 2018, really outlining high-intensity statin plus ezetimibe and PCSK9 inhibitor. So just a nice tool to use. Bempedoic acid is a newer medication. It became available in market about a year and a half ago, and it works similar to a statin in that it reduces cholesterol biosynthesis in the liver, but works a little bit downstream from a statin. The FDA indication is an adjunct to diet and maximally tolerated statin therapy for treatment of adults with heterozygous FH or established atherosclerotic cardiovascular disease who do require additional lowering of LDL. There are two options: bempedoic acid alone, which is called Nexletol, and bempedoic acid plus ezetimibe, which is called Nexlizet. These were studied in the Clear Harmony and Clear Wisdom studies, showing a 17 to 20% reduction in LDL in addition to the statin. And patients in this study, over 90% of those patients did have a history of atherosclerotic cardiovascular disease. But there's still waiting for outcome data trials, and I think there's one underway, and hopefully within the next year or two we may have some results for that. But for now, I do like to reach for bempedoic acid as an option, just another option in my toolbox for LDL lowering, because there have been meta-analysis showing really for atherosclerotic disease, the lower the LDL, the better the prevention and reduced event rate for cardiovascular and cerebrovascular disease. I'd like to focus now on triglyceride levels. Patients with atherosclerotic cardiovascular disease on recommended lipid therapy may have residual cardiovascular risk if their triglyceride levels are elevated. In moderate hypertriglyceridemia, we're looking at a triglyceride level of 175 to 499. And these triglycerides are carried in very low density lipoproteins, which are atherogenic and could increase your risk. Icosapent ethyl, it is a EPA derivative, was shown to reduce major adverse cardiovascular events and ischemic stroke in a clinical trial, and that's really led to FDA approval and in addition to the stroke guidelines. This is the Reduce It trial published in the New England Journal of Medicine in 2019, where over 8,000 patients with atherosclerotic disease, 70% of which with ischemic stroke or TIA, were followed over 4.9 years. Fasting triglyceride levels in this study were 135 to 499, with an LDL on a statin 41 to 100. Icosapent ethyl, 2 grams, 2 capsules twice a day with a statin versus statin alone. And it did show a 25% risk reduction with a number needed to treat of 21. And with this pivotal, trial, really led to a triglyceride being part of the guidelines that were outlined in 2021 for secondary stroke prevention. And I'll let you kind of read through that and use that as a reference. Vasipa, things to kind of consider. Vasipa with blood thinners, you may want to monitor for bleeding symptoms. In a clinical study, 12% on treatment versus 10% with placebo. Could be concerning for atrial fibrillation or aflutter, 5.3% for the treatment arm versus 3.9% in the placebo arm. So something worth watching for in those patients, and could be contraindicated for patients with a fish hypersensitivity. But a good option, really demonstrating furthering risk reduction. In terms of monitoring, the guidelines also mention, we should be monitoring our patients every 4 to 12 weeks after initiating a new medication regimen or dose adjustment. And so that's something that we do in our clinic, and it's a 1A guideline recommendation. And then you can recheck every 3 to 12 months based on the need to assess for adherence and safety. And there's been studies that showed that when you do monitor very closely, you're improving adherence, patient adherence to the medication with long-term follow-up, and making sure that long-term their risks are modified with ongoing treatment with those medications. And I would be remiss to not mention there are other options that are non-pharmacotherapy that we can really strive for and discuss with our patients for lowering the risk and lowering LDL, and that's with nutrition, physical activity, and weight loss. And these are some of the recommendations that are part of the guidelines as well. So again, here are my key points. And just in summary, I want to reinforce that there are many lipid-lowering options for atherosclerotic cardiovascular disease risk and stroke prevention. and my reference here. And thank you so much for your attention today.
Thank you. That's a comprehensive, excellent review of lipids. I definitely need to reread this multiple times because there's a lot about lipids that could be applied in clinical practice. So I wanted to know a little bit about your role in the clinic in secondary prevention, especially with lipids.
Yeah, I think I have a really great opportunity where I get to help patients follow up from a history of stroke or a recent stroke in the clinic, and I think that this has been successful for really three reasons. In order to look at different options for reducing the risk. And number one is there are multiple options that you can use, different therapies that you can use to discuss with your patients with the different pharmacotherapy options. And I've really gotten a lot of support and confidence from our vascular neurologists to be able to do that in the clinic, where I will see a patient very quickly after a hospital discharge to make sure that therapy treatments are on point, that we're monitoring and checking for lipid management. And then if we need to further, consider other options like a PCSK9 inhibitor, we have the staff support to be able to help with that as well, and patient coordinators helping schedule and working with prior authorizations and really helping in a pivotal way to help our patients in this way.
Great. Thank you so much.
Thank you.
I've asked our speakers in this block to tell me either a fun fact about themselves or their favorite subject. And Wiese had a really interesting fun fact that he worked in Thailand for an entire year during high school.
Yeah, I was an exchange student with the American Field Service, the AFS program in Thailand, my entire junior year. So I missed my first prom in high school, but it was a really worthwhile and really fun experience, and I really enjoyed that.
Great,
Yep.
Great. Well, thank you very much.